Welcome to AETCM, the emergency medicine channel. Today, let us discuss about drowning or submersion injuries. There are some definitions for drowning. According to 2002 World Congress on Drowning held in Amsterdam, there is a definition that is a process resulting in primary respiratory impairment from submersion in a liquid medium. So, here there is a entry of liquid into our airways. That liquid prevents the oxygenation of our blood. That is the most important thing which is happening in drowning. The mechanism of hypoxemia can be due to entering of water inside lung, or it can be due to asphyxia, that is laryngeal spasm can occur. So various mechanisms are there, but ultimately it will lead to hypoxemia. There are some terms like wet drowning, dry drowning, near drowning, secondary drowning, silent drowning. There are a lot of other terminologies which are not clinically very important. When we are managing the patient, we have to treat the asphyxia and cardiac arrhythmias. But whereas as forensic experts, all these terminologies are very, very important. But as a clinician, when we are practicing in an emergency room, these terminologies will not help you to treat the patient. So, drowning is traditionally defined as respiratory impairment secondary to submersion in a liquid medium. It can be non-fatal or fatal. Non-fatal was previously known as near drowning. Drowning leads to hypoxemia. That hypoxemia can lead to hypoxic injuries, various organs in our body, and it can even produce permanent damage to brain, and it can lead to vegetative states. At least 1/3 of the survivors sustain moderate to severe neurological sequelae. So, duration of submersion gives the risk of death or poor outcome. 5 minutes, 10%, 6 to 10 minutes, 56%, 11 to 25 minutes, 89%, more than 25 minutes, 100% mortality. So, this mortality may slightly vary on the warmthness of water or cold water. The survival may be better than in warm water. But clinically, all these things are not very, very important. We have to treat the patient who is a drowning victim, that's all. So, whatever may be the clinical finding, according to that, we can treat. Drowning sometimes can be classified under two important headings. One is cold or warm water injury. Warm water drowning occurs when the water temperature of 20 degrees Celsius or above. The cold water drowning at water temperature less than 20 degrees Celsius. Additional classification may include the type of water in which the submersion occurred, such as fresh water, salt water, natural bodies of water versus man-made water. So, all these things are important when we are treating the patient, and patient can have a lot of complications during the recovery period or during the survival after acute phase, whether it is warm water, cold water, saline water, fresh water, man-made ponds. So, various organisms, various electrolytes, the salinity may be different in various type of waters. So, that can produce long-term problem in a patient who is drowning. Long-term means acutely patient may survive with the same treatment, but after that aspiration pneumonias, some organisms are very common in sea water, some organisms are very common in fresh water, and salt and other minerals may accumulate in the alveoli after drowning from a sea water drowning. So, all these things are slightly different in various types of waters. So, drowning can be a primary event without any leading cause, or it may be secondary to patient might have developed seizures, head or spine trauma after diving into the pond, cardiac arrhythmias, hypothermia, alcohol and drug ingestion. That is one of the most important problem in patients who develop drowning, alcohol and drug ingestion, syncope, apnea, hyperventilation, suicide, hypoglycemia. All these things are very important. Most of the time in children it is accidental. The term near drowning is not used nowadays because The treatment all depends on the clinical finding, whether it's a near drowning or complete drowning, partial drowning, full drowning, whatever it is. The treatment all depends on the how much hypoxemia is present and how much brain damage is occurred due to this hypoxemia. There is no major clinical difference between salt and freshwater immersion, but aspiration contents may vary from salt water and fresh water. The bacteria or organism which is present in the salt water may not be seen in fresh water. So, all slight difference is there, but clinically all these things are not very important in emergency room. The most important diagnostic feature are the duration of or severity of hypoxemia. That is very important. Submersion, voluntary breath holding, initially it can occur. Then suddenly patient may take breath inside, that leads to aspiration. Then there will be severe laryngospasm that will produce hypoxemia and death. Aspiration destroys surfactants, that also a probable cause for ARDS in the lungs, that will lead to ARDS like clinical feature and VQ mismatch. Hypoxemia is the major problem in drowning, like what we discussed previously. The cause may be aspiration of water inside the lungs and reduces the oxygen diffusion. Then laryngeal spasm also can produce severe breathlessness. Third one is silent bronchospasm. Those who are having asthmatic episode, if they drown, there will be severe bronchospasm because of aspiration. When you auscultate, you don't get any clinical finding. This is sometimes called as silent chest. So, silent bronchospasm is a deadly condition along with aspiration with laryngeal spasm. Brain hypoxemia and brain edema will occur in many patients. Generalized tissue hypoxemia may lead to hypoperfusion and lactic acidosis. Aspiration can produce pneumonitis and it can be chemical or it can be bacterial or any other organism. Sometimes it can lead to ARDS also. So, when the patient is drowning, there are two important mechanisms we already seen that. One is aspiration of water into the lung, that reduces the oxygen diffusion. Second thing, like suddenly patient aspirating, they develop spasm of the laryngeal area, that produces asphyxia. Third one, patient who is prone for asthmatic episode, they can have bronchospasm also. Ultimately, it will lead to brain edema, brain injury, brain death. Now, water types, clinically when we are managing in emergency room, that may not create any problem for the patient acutely, but later afterwards these two types of water, whether it is fresh water or salt water, can produce slight difference in the clinical prognosis afterwards, not initially, because the salinity of the water is different. That can accumulate for a longer time, that can produce more damage, and the organisms in fresh water and salt water is different. So that also creates problem. Like types of pneumonias, aspiration pneumonias are different in both types. But a forensic expert, these type of changes are very, very important. Whether it is a dry drowning, wet drowning, salt water, warm water, all these things are important for a autopsy finding and their correlation. This type of knowledge is very important, but not for an ER physician. Now, ARDS is one of the important problem of drowning. ARDS can be seen in various other problems. You might have seen it is common in infection, it is common in inhalation, it is common in drowning. It can be common in multi-organ dysfunction syndrome, other conditions like SLE, rheumatoid arthritis, all these things also ARDS is common. So, ARDS is not a disease, it is an expression of lung damage produced by various type of diseases. Here also ARDS can occur in many patients. ARDS is a non-cardiac pulmonary edema. Causes are near drowning or drowning, over inhalation of toxic fumes, trauma, blood transfusion, central nervous system related problems, aspiration of gastric contents, radiographic contrast, drug overdose, infections, alveolar hemorrhage, cardiopulmonary bypass. Pneumonia is another important problem of drowning. There are a lot of organisms can produce pneumonia, but in that some are very important. They are uncommon, but we should remember about that. Aeromonas is one important infection. Burkholderia, that is very very important when the patient develops drowning in salt water. So there are other organisms also can produce pneumonia. Sometimes chemical pneumonia can also be produced by drowning. So pneumonia can be due to aspiration of bacteria. Pneumonia can be due to aspiration of chemicals. Both are possible. When we are seeing pneumonia, don't think that it is only an infection. Procalcitonin level may be elevated in infective pneumonias. Many patients develop severe hypothermia after drowning. Prolonged drowning leads to severe hypothermia. Theoretically, this hypothermia is good for brain, theoretically only, because when the patient go for hypothermia, their whole metabolism will come down, including brain metabolism will come down. So when there is hypoxemia to the brain, when the metabolism of brain is slowed down, it can be theoretically an advantage for brain. But clinically, when we are practicing, this is not the case. Drowning means hypoxemia. Whether you drown in a cold water or warm water, clinically it may not produce much difference. Hypoxemia can produce permanent damage to brain. So that's what we discussed. Hypoxemia, theoretically it is good for brain, but practically they are not very very useful. Some minor advantages may be there, but when we are practicing in emergency room, what we see, drowning means prolonged drowning with severe hypoxemia produce permanent damage to brain. Whether you drown in cold water or warm water, it is not clinically very relevant. Now, when we treat a patient, first aid is always very important when we are treating the patient in a spot, in an area where there is drowning is very common. First aid given by lifesavers are very very important. So when we give first aid, always remember that there is a high chance for cervical spine injury in most of the drowning victims. Either it can be due to fall from height to the water and hitting on the ground. Second thing, they can have this drowning due to seizures or any other injuries. So cervical spine stabilization should be done for all patients who is having suspicion of drowning injury. Then all patients' oral cavity should be cleared, because sometimes fish or any other material can go inside and block the airway. So try to clear the airway with your hands. That is also very important. Third one, we can start rescue breaths. So what we have to understand that in drowning, more than cardiac problem, it is a respiratory problem. It's an hypoxemic problem. So forceful pressurized air into the lungs are very important. So rescue breath has to be given for all patients who develops drowning. Most of the time we give 2 rescue breaths. Some agencies that regularly treat this type of patient, they also recommend 5 rescue breaths should be given initially itself, because they know that the main problem here is hypoxemia. When we compare with ATLS or other types of trauma, here the main problem is hypoxemia. So in ground we don't get oxygen, we don't get support of oxygen system. So it is always better to give mouth to mouth respiration. So 5 rescue breaths can be given in this type of patient, and immediately we can start CPR. Some investigation in emergency room are very very important. One is you can take a chest X-ray to see any aspiration contents are there in the lungs. C-spine X-ray should be taken when any other injury is there. ECG should be taken because many patients can have bradycardia and Osborne waves that we will see afterwards. ABG should be taken. Many patients can have lactic acidosis because of hypoxemia. Always take care of the patient's airway, breathing, circulation in emergency room. Jaw thrust maneuver is the best way to open the airway and see anything is there in the mouth, and oral cavity should be cleared. rescue breath has to be given, and spine should be stabilized in neutral neck position. If required, patient may be intubated as soon as possible in emergency medicine itself, because many of these patients are having hypoxemia with severe brain damage, initial brain damage. Their oxygenation has to be taken care. We will not be able to use NIV because their GCS will be very low. So better to intubate this type of patients initially itself. Early intubation is very, very important. With a PEEP like ARDS, high PEEP should be kept. But NIV should be used only if the patient is having good GCS or if the patient is cooperative. Otherwise, intubation will be better. Now, ECMO, we know arterial ECMO is extracorporeal membrane oxygenation, is one of the treatment modality we use in ARDS. Here also it is something like ARDS. Water has gone to the alveoli, that has reduced the oxygenation. It will take some time to remove that water from the lungs. We can try with ventilation, we can try with high PEEP, but sometimes it may not be possible in acute settings. So some patients, we know arterial ECMO is better than simple mechanical ventilation. Now, rewarming is very important. Rewarm the patients with core temperature less than 34 degrees Celsius. Passive rewarming can be achieved with blankets and warm room. This form of rewarming will not be effective for a patient in cardiopulmonary arrest with severe hypothermia. So, passive rewarming should be done in a patient who is having normal hemodynamics. Other things you have to go for active internal rewarming techniques. And their body temperature is less than 30 degrees Celsius, we have to definitely do that. So, warmed, humidified oxygen, extracorporeal membrane oxygenators, peritoneal lavage with warm water, intravenous administration of warmed ringer lactate or saline should be given. Esophageal rewarming tubes can be tried. So there are a lot of rewarming techniques is available in this chart. You can see this. I am not going to explain everything in detail. We have bladder lavage, gastric lavage, peritoneal lavage, thoracic lavage. They are all coming in active internal lavage that should be tried in patients with severe hypothermia less than 30 degrees Celsius. So prolonged hypothermia can produce consumption coagulopathy and thrombosis consumption coagulopathy and DIC sometimes. So to avoid that, we have to actively rewarm these type of patients. Some patients may require veno-arterial ECMO, that also we have seen, and many patients may require mechanical ventilation if their GCS is very low. Automated defibrillators are very important. It can be used in the spot when the patient is arrested after drowning. Before reaching the hospital, we can use AEDs. Up to 3 shocks are advised in this type of conditions if there is a shockable rhythm. But after that, we have to start CPR. High quality CPR has to be initiated as soon as possible. We can give 30:2 compression because hands-only CPR is not recommended in drowning. We know that the main problem is drowning. In drowning is not the cardiac problem; it is the respiratory problem. So by doing hands-only CPR, we all know that there will be some ventilation happening, but that is not an adequate ventilation for a patient who is having severe hypoxemia. So mouth-to-mouth respiration has to be given on the spot. When the patient come to emergency room, there we can go for BLS protocol or ACLS protocol. According to standard ACLS only, we can continue this type of treatment. But as you know that the patients who drown, their response to your routine treatment, like whether it is CPR or whether it is drugs, it may be delayed because their circulation is not good. Their metabolism is in a lower state. So till the patient is rewarmed, you cannot get a good result in severely drowned patient. So ACLS management is like any other patient who admitted with cardiac arrest. Only thing, we need to give some more time to the patient, and the injections, whatever injection, whether it is adrenaline, noradrenaline, atropine, all these things, you have to space the timing. Suppose it is every 3 minutes in ACLS protocol, you can slightly delay it to by 6 minutes. That is because we know that when there is drowning, there is severe hypothermia, so the circulation is not proper. It may not occur like a normal person, and the metabolic activity is also low. So till the patient is rewarmed, you have to slightly deviate from the ACLS protocol, but the protocol is same. ACLS protocols are same, only time is little delayed, that's all. So for the reason, intravenous drugs are often withheld if the victim's core temperature is less than 30 degrees Celsius. So if you are giving drugs like ACLS, it has to be slightly delayed. So always wait for temperature to go above 30 degrees Celsius to declare the patient even dead. No death is documented until the patient is warm. So that we have to be very careful. Before the patient's body is warm, you cannot declare the patient is dead also. Till then, we have to continue the CPR. So prolonged cardiopulmonary resuscitation is recommended in drowning. That is because of the hypothermia. And many patients can come back with normal CNS functions if you do it properly in emergency room. But slight delay or slight more aggressiveness also sometimes can create more problem. So we have to be very careful when we are managing drowning patient. This is one ECG finding, that is Osborne waves. You can see the J point itself is elevated. That is a classical finding seen in hypothermia. It is not a finding seen in drowning. If the drowning leads to hypothermia, you can get bradycardia and this type of findings. So rapid core rewarming, we have seen the techniques. There are a lot of techniques to do this. You can give humidified warmed oxygen, warmed intravenous fluids, peritoneal lavage. All these things can be tried. So this is an algorithm which will tell you how to manage drowning. We have already explained all these things. I am not going to this part again and again. Only thing is, when we are managing drowning patients with cardiac arrest, we go according to ACLS protocol only. But the timing is slightly delayed. Whatever drugs we are giving, the timing is slightly delayed. Until the patient's core body temperature is elevated, we cannot even declare the patient is dead. So that two things we have to be very careful. Other things are almost same. So this is a bigger chart, will tell you grading of drowning. I am not going to the details of that. You can read about this chart, and that will give a complete outlook of drowning management in emergency room. So we have discussed about one of the important cause for death, that is drowning. Many deaths are already like prevented by lifesavers in this type of areas. They are well trained. Most of these lifesavers are well trained in BLS, ACLS, all these protocols. They are well trained in most of the centers. But even then, some patients may come to hospital in emergency room, especially in our country. These life-saving protocols are not well developed, so they all depend on the emergency doctors or emergency technicians to save the patients. A lot of unwanted things may be done in the field, like a patient may be taken and they may press on the abdomen. So after drowning, we can see many public may give cardiac compression, thinking that compression on the abdomen is life-saving in this type of patients. Actually, that produces more adverse effects than benefit. This water from the abdomen may go to the lungs, the patient may aspirate. So unnecessarily all these things should not be done, but unfortunately it is happening every day. So the drowning victim which is coming to emergency room in India, and that is different from a drowning victim coming to an emergency room in a Western country, because in the field most of the time these patients are managed well by a trained person in that area. But in our country, very selected places we have these trained persons. Most of the areas we don't have trained persons to save the life at the spot. So these patients may come to emergency room in a bad state. So we have to take care of this type of patients. Thank you.